So today I'll be talking about understanding and managing the mental and physical effects of long COVID. This is a pretty dense, longer than usual presentation, so I'll try to move through as quickly as possible. Think of it as a resource you can reference back to see the details and what options you have. And in the future, we're looking to divide into two different talks about understanding long COVID. There's so much new information all the time. And a second talk might be about the management in more detail, but I'll try to go over it at a higher level today. These are the disclosures. There's research relating to ECHO that's funded by CHR and U of T. The companies that are listed for diabetes care, so no conflict with these talks. And I'm also the clinical lead for primary care integration with the Ontario College of Family Doctors and work with Canadian Partnership Against Cancer as well. So this talk actually is also added to with information about mental health from Sanjeev. There's a family doctor from England, Trisha Renal, who actually does amazing work on long COVID there, and you'll recognize some references to links there. And our great CAMH librarian, Rena, who also added more resources that I'll be referencing in today's presentation. So this is an update from the presentation I did about a month and a bit ago. COVID changes so quickly, there's a lot of information understanding each time. Wherever possible, we'll give you the clear evidence base. There's some stuff that's evidence informed, but the majority is evidence based. And so far, there isn't anything that's off label yet in the conversations. So we'll look at understanding the difference between acute and long COVID, the complications we tend to see from it, and approaches to care that are consensus based. So what is COVID-19 itself? We already know a lot about the virus and the symptoms that it gives you immediately. So that was the easy part. We debated ad nauseum about it in the beginning, but the truth is that is the simplest part of the whole equation. What we do know very clearly now is COVID-19 is not just a respiratory illness, it is primarily a vascular endothelial disease. And that means it attacks the lining of your blood vessels through the ACE receptor, and that goes pretty much everywhere in your body. Other tissue types also have ACE receptors, but the blood vessels especially do that. And that means that you have damage consequent from there. What happens is you have inflammation of the lining that causes leakiness that can cause fluid to remove. The endothelial lining is also a very immune activating area because that's what gets damaged when you have infections or trauma. And so when the endothelium gets damaged, it actually releases a lot of hormones and cytokines to attract immune cells to the area for repair. And what happens with COVID is you see clots forming with a roughened endothelium when it's damaged. You see a lot of hormone activation. You get that cytokine storm, which has actually caused damage and harm to people in acute COVID, but also leads to a lot of the things we're seeing with long COVID. And for example, this is a picture from the lung, where when that vascular lining got damaged, you had leaking of blood and serum into the fluid space of the lungs, and that was the drowning acute respiratory stress syndrome that people had when things are really bad acutely. But we're also seeing changes that happen in the long term with this endothelial damage. So what's in a name? So there've been so many different names for the things that followed long COVID, followed COVID acutely. The official name is at the bottom there in blue. That's a post-COVID-19 condition labeled by the World Health Organization. And those defined in October of last year. I'll give you the definition for the case right now. They named the condition very specifically. It is not a syndrome like we talk about chronic fatigue syndrome, other things, which is simply a collection of symptoms. But now there's definitely an agent that causes it with COVID, unlike other syndromes. We're not sure where it even comes from, though we're learning more about the exact specific steps in the damage it causes. Colloquially, people call it long COVID, and that's what's the most common usage in the world for people to understand and that seem to like. But people tend often not to like as much as long hauler COVID. They don't want to be labeled by their illness, and that's an important thing to remember because we don't want to make it seem pejorative. So what causes long COVID? There's a couple of different hypotheses out there, and there's more and more evidence. I'll share some of this, kind of cementing this into a bit of more fact. We believe there's damage from oxygen deprivation. So hypoxic injury, when a blood vessel gets damaged, the tissues around it don't get blood flow, and you get damage happening acutely with COVID. Some of long COVID might be resulting from that damage that happened originally, or it might be ongoing reduction in oxygen flow. There's clots that form, and the damage we talked to from that. Bleeds that happen when you damage blood vessels as well. And what we're seeing is a lot of inflammation, so immune dysregulation that persists after COVID that keeps on causing more harm. And more, there's research into what they call persistent virus or viral fragments. Now, this is not persistent virus infection that we're seeing with herpes viruses or chickenpox viruses, where the same active virus reproduces and goes on in you. We don't see that so much with COVID. What we're seeing instead is fragments of DNA and proteins from COVID left over in tissue, causing ongoing inflammation. So these causes are all actually interconnected. They interplay in the body to cause these symptoms. So how is long COVID diagnosed? This is the case definition that WHO gave last year. And essentially what they said is a history of probable or confirmed SARS-CoV infection, usually happening within 3 months of the onset of the actual infection, and symptoms lasting for at least 2 months that can't be explained by an alternative diagnosis. So this is a diagnosis of exclusion when you rule out other things. Now, having said that, there's already movements happening in UK and elsewhere to begin to recognize that actually looking to investigate every other cause of a symptom before you call it long COVID probably isn't the right approach, that it may need a positive diagnosis. You can treat it like what it is rather than guessing, is it a rare illness that's happening, presented this way, or the most common thing nowadays, it actually probably is long COVID when you see it in a constellation. So there's many different symptoms. I'll go through them in more detail in a moment, and they impact daily functioning significantly. There may be new starting after the initial infection, or sometimes the initial infection seemed okay, and these symptoms start afterwards. And they can go up and down, and that's the nature of long COVID. We know that there may be a slightly different definition coming out for children, but it hasn't been formalized yet. So early in 2020, and with an updated version sent in 2021, in the UK, they started with the NICE guidelines, which is a collaborative effort in this case with the Royal College of Family Physicians, as well as the SIGN group from Scotland. It was a really good rapid guideline for managing long COVID, which is still very valid today. And so the questions they asked is, will you only call it long COVID if you have a positive test, like a RAT test or a PCR test? Not those tests, so you'll be missing a lot of cases. And especially now, you can't even get access to the testing formalized in many areas. For example, in British Columbia right now, families only get 1 pack a month of the rapid tests, which means that most people never have the chance to test for it, even if they wanted to. We only count severe illness when you're hospitalized. Well, we know now that misses a lot of cases, and long COVID happens in people who didn't have severe illness to begin with even. You only look for pictures or radiographic image evidence of organ damage. A lot of the time when we do pictures, they look normal in our gross, not very sophisticated imaging, even though there's actually symptoms happening. And you only rely on people who had symptoms initially with COVID. Well, the problem is some people have very varied symptoms. They come and they go, and some people had asymptomatic COVID and still have long COVID later on. So in the end, the consensus was the only way to know it reliably was to look at the clinical history. If there was a likely exposure and the symptoms fall there in the constellation of long COVID, that probably is sufficient at this stage. In the future, we may have more serology antibody testing to confirm, but for now, this is what we have. So how long does this COVID itself last? So the acute infection is typically 2 or 3 weeks, by which point you're resolved. The virus is typically cleared from your body by that point. So the post-acute phase is from 12 weeks or up to 12 weeks or later. Now, I've divided that post-acute phase into 2 parts, that 3 months and more than 3 months, because a lot of symptoms tend to improve within the 3 months. And then you're seeing a different proportion of patients with more significant issues who last more than 3 months. So it's a good dividing line to understand, though all of it is technically considered long COVID. So how many people does long COVID affect? So we had data early on from research suggesting between 33 and 90% of patients had long COVID symptoms. Public Health Agency of Canada put that 83% in the first 3 months and then about 50% after 3 months. And they haven't changed their guidance on that systematic review since then. Just recently, we have early data from the CAMH study. That's the one run out of Toronto, but for all of Canada, looking at long COVID treatment and management. And they've recently confirmed at 3 months, they're still seeing 50% of people having long COVID and nearly 40% having it at a year. That's very significant. This is a bit different than numbers you'll see elsewhere in the world. They're a bit lower, but there may be some challenges in how they report it or classify the illness. So in general, we're seeing a consensus of at least 20% or so to 30% for initially. And as we're seeing, we're having data now suggesting it's higher than that. We just weren't very sensitive initially picking it up. So now there are differences in COVID when it comes to sex here. So for males and females, we see differences in how we react and what to worry about and when. So we know with acute COVID, men are more likely to catch the infection and maybe sociological reasons or even immune evolutionary reasons. They're also just as likely to be hospitalized, be in ICU, need ventilation, and die. Whereas women are much more likely to have long COVID. And that's nearly a 20% excess risk there. And this is a breakdown of some of the symptoms. Again, women have a lot more symptomology for most of the symptoms except for kidney and endocrine, where men tend to have a bit more of those when they do get long COVID. How about kids? So early on, Italy estimated with a very formal study, more than 50% of kids had long COVID, even at 4 months' time. and half of them had functional impairment, things like breathing and thinking clearly. The UK had a lower rate, but they relied on self-report more, and wasn't validated in the same rigorous way. And so they found about 15% of kids. They've tried to say it's a bit lower recently, but again, their data kind of seems to show actually maybe higher than that overall. Most recently, there was a large systematic review and meta-analysis that actually did peg the number at about 25%. So somewhere between 20% probably is a safe margin to estimate in most cases for kids. So what happens with the variants? And we're beginning to see some differences. So there was a study from the UK just published recently using that same Zoe app that patient reports having symptoms. So this may be an underestimate overall, but what they said was they felt that with Omicron compared to Delta variant, and Omicron is the variant that seems to affect more upper airway rather than lower airway in your lungs. So kids get more asthmatic symptoms, but you don't have the same degree of respiratory distress that we saw with the original COVID as well. So they thought it was maybe a fair bit lower with Omicron. However, because there were so many more infections that were happening because of Omicron, they actually had more people with long COVID during the Omicron wave than they had during the Delta wave overall. There's some limitations in the study in the attribution, but this is at least some hope that we're getting some sense. There may be some confounding variables of vaccines I'll come to in there, which may seem to make it lower when it actually isn't lower. So how long does the symptoms last? The good news is they tend to get better over time. You can see the graph coming down on the left there over 35 weeks. We also have some signals early on to let you know, is this going to be a bad case or not a bad case? So typically, if you're having symptoms getting more severe after the 2-month mark, you're more likely to be bad even at 7 and 12 months. If you have more numbers of symptoms getting worse by 12 months, meaning the numbers of new problems are increasing, then you're also the kind of person more likely to have issues at 7 months than the people who seem to be getting better by the time you hit that 2 to 3 month margin. More recently, we had confirmation that 70% of long COVID patients had symptoms still at more than 3 months, and 1/3 had symptoms for more than 12 months. So it seems to last a lot longer than the initial hypothesis led us to believe. So we remember the background of this graph, which is one we also for the waves when Ontario was getting going to understand what they didn't depict was a long COVID, which isn't simply a point in time of one case happening and it disappears, but a cumulative under the curve. All these people carry on, as we now know for extended periods, carrying on cumulative burdens in the society of long COVID. Even if we estimate a low 10 to 20% rate of long COVID, that would put us now in May at about 388,000 Canadians with long COVID and about 150,000 in Ontario. That's a massive number, especially recognizing these numbers are based on the official COVID case counts, which we now know are significantly under counts of real counts. So probably about double that many Ontarians with long COVID right now. So what symptoms in particular do we see with long COVID? The description from the Wounded Healer study from the UK, which is healthcare workers who got COVID early on, were words like just can't function, brain fog, lung burn, and trouble sleeping. And this was affecting their work, and I'll come to that again today. From a medical perspective, this is a good graph on the left. The blue shows you what people have in terms of symptoms for acute COVID and how those symptoms change when they transition to long COVID in the red there. So you see things like joint pain actually still persisting pretty well into long COVID, whereas muscle aches actually seem to mostly go away when you become long COVID. So they can tell you what to watch for more or less in what you see with patients. There's also a bit of evidence that the different variants, wild type original COVID versus the alpha variant, which was from the UK initially, they're looking at loss of smell, difficulty swallowing, impaired hearing, being part of the wild type, but less common with the alpha variant. We don't have the data on Delta or Omicron as clearly, but muscle aches and pains, insomnia, brain fog, anxiety, and depression were more common with the alpha variant. So there's a lot of symptoms from long COVID now documented, more than 203, affecting different systems. Later on, whenever you have a patient or client or family or friend with long COVID, this is a good graph to go back and look at to see what symptoms you're having, which body part exactly, and then you can see when they seem to get worse and when they seem to get better, because some symptoms get better faster, and that can give you a trajectory to expect to see in long COVID. What we recognize, and Devisho said right from the beginning, functional disability is a big part of long COVID, and so their intake form really clarifies that. We have recent data showing that even at 6 months post-infection, among hospitalized patients, these are not people in the ICU. They were just in the hospital for a night or 2 nights and sent back home. I have a lot of them in my own practice, actually. But at 6 months, there's a significant drop in their functional abilities. Their disability scores tend to get worse, and they're unable to return to work as much. In patients who were at home as well as hospitalized, most of them who went to work still had a significant reduction in their work hours. So capacity is going down. And what does that mean for us as society? Just yesterday, you saw the big announcement from Quebec showing that 6 hospital emergencies had to shut down because they didn't have enough staff, more than previous years. And then the ministry clarified that 10% of those losses were due to long COVID. So we're seeing a lot of that, and that's going to be a big issue. It's actually worrying the economic forces. There's a big study and report from an economics journal earlier in the year that looking at the labor shortage. We know we're hearing about, unemployment being the lowest rate, companies can't handle it, it's not working, they can't get back. Well, they keep on making lots of excuses for why they think it's happening, but there's now an estimate that up to 15% of unfilled jobs already are due to long COVID right now. And what does that mean for our society functioning as we go forward? So governments have recognized the risk of this. In the US, the Human Health Services Department has already issued guidance on long COVID under the Disabilities Act. The government of Canada clarifies still they expect about 10% unable to return to work. And just yesterday, you had the first international case law clarifying that long COVID is a disability under the law, and actually they can be used in discrimination cases. Now, you need this case law to support patients overall. And in Canada, we follow British case law as well. So this would have impacts in how patients are facing, and they're covered here as well. So now we'll go to the more that science emerging, showing us exactly how is long COVID affecting our organs. So this is a summary graph that shows you through the ACE receptors, different body systems, and the symptoms you seem to have when long COVID affects them, and you can read them in more detail later on, but I'll go through specifics here. So beginning with the heart, the cardiovascular system. So they've now shown, and this, whenever I'm having these busy graphs, you'll see a bit of indicators there to make it easier. When you see that little red house, that means we're talking about people who never went to the hospital for long COVID. The blue person in bed is when people had to be hospitalized for COVID. So we know they're very different trajectories. People who have more severe illness are more likely to have more severe long COVID as well. And so the majority of people will be in that red house space. So mild disease, not hospitalized, saw their risk of a heart failure actually going up 40% over the next year, and the risk of a clot in their lungs, which can be deadly, going up more than twofold over the next 12 months. So even the mild COVIDs, you got to watch them for the next year for lung clots and other issues as well. Those hospitalized had a significantly higher risk of having heart attacks and myocarditis. Now they've more recently proven that even when they follow the same patients all the way past a year after they had COVID, that their heart attack risk remained 4 times higher, and their stroke risk remains 6 times higher for the next 12 months, even after their mild, sometimes even asymptomatic COVID. And this is true for all age groups. Compared to their baseline risk at 18-year-old having a heart attack, it's now 4 times higher. The risk of 40-year-old having a heart attack, it's now 4 times higher than their base. So at a lower age, it's still a small absolute number increase of risk, but relatively speaking, you're seeing a lot more 18-year-olds having heart attacks, 4 times as many as you did in previous years before COVID came around. And that's going to have an impact on everything from cell functioning, individual learning, and economy as well. So scarring in the lungs or pulmonary fibrosis, we saw that with the previous versions of coronavirus, so SARS and MERS. You have about 10% of patients initially, getting down to about 3% of patients, so 1/3 reduction at 15 years, but still persistent. We knew older people, those who had other illnesses, who tend to have diabetes, hypertension, cardiovascular disease, had more problems. And it seemed to persist. It got better, but it actually did persist to some degree, and there was impaired lung function that persisted. Looking more recently as well, a Swedish study of 1 million patients, which were matched for age and gender with a lot of controls, they're also compared and found that after COVID-19 infections, the risk remained really high for having the clot in your legs. So that's the one we worried about, people taking long flights or being on birth control or smoking, having clots in their legs. Well, COVID causes a significantly increased risk there, and that remains elevated at, even in mild disease of COVID, 3 times more than normal. So that's even higher than birth control, for example, or smoking causing DVTs. Clots in the lungs also remained elevated for 3.5 months, and bleeding was higher for 2 months. Kidneys have a lot of ACE receptors, and that's a big area to worry about with COVID as well because of that. So this is a study where they looked at almost 2 million patients, and they looked at their data. Every single day they tested their kidney function, and using that they modeled to expect what to see in the future for these patients. So in the mild, not hospitalized COVID patients, they saw that nearly 1/3 had acute kidney injury, and they estimated they're twice as likely to reach end-stage kidney disease in their lifetime. And that means they would need dialysis. So they're expecting a significant increase in the future of more rapid renal decline and dialysis. People are hospitalized, you're looking at a 13-fold increase in needing dialysis. So a pretty dramatic worry about what's going to happen to people's blood pressure, heart disease, and dialysis risks in the future. With diabetes, we've seen a lot of changes. So there's a bit of a two-way relationship with diabetes and COVID. So we know people having diabetes are a lot more likely to end up in the hospital. So almost 3 times as likely. And actually, if they do get COVID to begin with, the diabetic patients are also 4 times more likely to develop long COVID. So diabetes is a big risk factor for long COVID. Of the people who were hospitalized but didn't have diabetes and got in the hospital, 14% ended up needing insulin before they left the hospital. So COVID does a lot to damage their pancreas, it seems. And there is even histological evidence of that now. More concerning, what we've seen is that 30 days, children who got COVID were actually 1.66 times more likely, so that's an excess risk of 160%, of getting new onset diabetes within a month after catching COVID. This study looked in 2 different data sets, and they found one study said, this excess risk of 1.66 times, and the other study, which had a different criteria, said at minimum there was a 30% increased risk of becoming diabetic if you got COVID compared to the kids who didn't get COVID. Now, what's worth recognizing is that we know that type 1 diabetes, where your pancreas gets damaged and can no longer make insulin, is an autoimmune disease. Your body attacks itself and damages and kills off the beta cells. We know that other viral infections, including the flu, could and did cause more type 1 diabetes to occur in kids, but the rate we're seeing with COVID is about 3 to 4 times higher. So it's more likely than other infections to cause diabetes in children. And I just had actually a family friends become diabetic a month after having COVID just last week. What's happening is also these kids are presenting in diabetic ketoacidosis, so that's almost dangerous condition where they're not able to process the energy that they need, twice as likely that they used to in the past. So we're seeing a lot more serious presentations of children caught late becoming diabetic. And the evidence found that even people who are not overweight were ending up being diabetic after catching COVID. And obviously it's worse if you're hospitalized, but we're seeing it in the lowest risk populations. Coming now to the immune system. So what we've shown now reliably is that the immune cells, the regulation of the different levels of immune cells in your body remain really abnormal for 6 months at least, and they're peaking at 4 months. So 4 months later, your body's still revving in the wrong direction with the inflammatory process. And you have 2 kinds of immune system parts in your body. You have the innate immune system, which is the cells that don't need training or priming. Kids rely on this for immune system, which may be why they're better fighting off COVID faster initially. And the trained immune system, which is what we're training with vaccines, for example, the B cells and the T cells, and this is what adults rely on more. So what they also found is COVID can attach to other receptors in the body, not just this H receptor. And so when one of the macrophages goes and eats an infected cell to destroy it, which is what it typically tries to do, these COVID can actually attach onto the macrophages to a different receptor and infect the cell trying to kill it. As a result, that cell recognizes it's actually going to be overwhelmed by the enemy. It tries to destroy itself in a process called pyroptosis, which essentially unleashes this huge inflammatory storm in a cascade, because macrophages are big immune activators. And this may be responsible for the cytokine storm and ongoing inflammation we're seeing from COVID as well. So no surprise, when you activate the immune system a lot, you have a higher chance of having autoimmune disease happening. There's 2 mechanisms by which this happens in general in the body, not just from COVID, from other things. One is when your body's learned to fight something, if the molecule it's learning to fight looks like something else in your body, you might by accident attack the body too, and that's molecular mimicry. The other part is when you're releasing these hormones to activate the immune system, other cells that shouldn't have gotten activated by the immune system might be. And that's the bystander activation, where now you have your body attacking different things. Genetics has a role with this, as well as how severely ill you are, where you have more of these hormones flying around. What we've already proven now is you see a lot more of that flaccid paralysis syndrome, the Guillain-Barré syndrome, that happens after influenza sometimes. We're seeing the multi-system inflammatory syndrome, both in children and adults. It's a rare illness, but it's very severe. You see a month later, we had children die from it in Canada as well as around the world. And we're also seeing what we think are new autoimmune disorders, things we have not yet labeled because they're antibodies to things we have never seen autoantibodies to in the past, especially gut ones. So for example, right now we're investigating that hepatitis we're seeing in children around the world that we can't explain, that we think maybe might be a new adenovirus that didn't behave this way in the past, but we're also having a research study looking at, well, they actually had COVID, but not other viruses involved. So this might be what we call an autoimmune hepatitis that we've seen in adults with COVID, and now maybe also happening in a higher rate with children. People hospitalized are much more likely to have antibodies that look like lupus antibodies or or rheumatoid arthritis antibodies, or all these other kind of autoimmune disease antibodies. So we're seeing definitely the body being revved up to attack itself after COVID. We'll switch gears here and look at how people function and think here. So this is self-reports. Patients asking, were asked, how do you feel your brain is working? And so more than 30 patients who were never hospitalized, this is 3 times more patients were more likely to say they had memory deficits at 8 months and had reduced quality of life. And this persisted up to 15 months in follow-up studies as well. People who were hospitalized were 82% more likely to say they had neurological issues after having COVID, but it's a significant difference. 11% of people who had COVID who never went to the hospital still had issues with their thinking. But you might say that's self-report. So how about formal testing where we test them to see how well is your brain working? The UK has this ongoing study year to year for many years where they look at people's cognitive function just to see what's happening. And so they have a massive number of patients, 81,000 patients, who they had their testing before they caught COVID, and now they could do it after COVID, which is a very significant pre-post thing to be able to do. The graph there looks at how much their cognitive testing scores declined. So what they found is the people who were the most severely affected, who were in the hospital and ventilated, had nearly a 0.47, nearly a half point standard deviation drop in their cognitive score. That's almost twice as bad as the average stroke. And so that's significant and worse than being born with a developmental disorder. Even those who were in the hospital had damage half as bad as having a stroke. These are people who thought they're doing okay, but we're seeing now there actually is objectively a decline that's very significant in their cognitive function. A follow-up study looking at executive function also happened. So those of you helping patients plan care changes and where they go next in their life rebuilding efforts, there is a dose dependent. The more severe your initial COVID was, the more significant your functional executive decline is. We also have pictures. So see, like not only is it the testing there and the self-reported part differently, but the biobank study, again, a year after year study from the UK, had MRIs of people's brains before and after COVID. And they found everybody had significant shrinkage in the gray matter. And that was actually in many different parts of the brain relied there, but these are parts of the brain involved in lots of complex parts of our thinking. The scarier part is they could not tell the difference from looking at the brain pictures if this is a hospitalized patient or a not hospitalized patient. Everybody's brain got damaged. What we're seeing there is the function decline is worse in the hospitalized patients, not as bad in others. So what may be the case is people who are more vulnerable, this is a hypothesis, who are already more sick for other reasons, may have less functional reserve to compensate for loss in brain function. But what does it mean for the rest of us who are functioning well right now? And what does it mean for us in the future when we have other tolls to carry as well, and how well we keep on holding our independence and cognitive function? So there is a worry, and this is already being sounded by the geriatricians, of a dementia concern in the future for all of us. Mental health also is significantly affected by COVID. New onset psychiatric conditions are 18% after having COVID, and that goes across the spectrum of mood and anxiety disorders. You can see the ratio changes there. Even when we're seeing the hospitalized patients who have delirium. So 80% of delirium, and it lasts twice as long as delirium from other causes typically in the hospital. So it's a more severe, more lasting effect than we're seeing, and that does worry us as needs. Post-traumatic stress disorder is unsurprisingly worse, and the first 3 lines there are all the various coronaviruses, and so the red dot is COVID, but we're seeing this is actually worse than being in the tsunami in Japan or at ground zero when 9/11 happened. This is more likely to cause PTSD for patients, nearly 20 to 30%. So how do you plan treatment for long COVID? So I'm a family doctor, and we're very close to public health in terms of prevention and population health issues. So preventing long COVID seems like the best idea at the moment, and I'll go through the evidence for that as well. So in your choices, we recommend definitely using the N95 masks, and they're better than the KN95, which is the Chinese-made certification ones that have the ear loops, or the Korean KF94s, but they're still decent if you can use an ear loop behind it to make it tighter. And these are significantly 30–40% more likely to prevent you from catching COVID if you're in an environment that's high risk compared to a surgical mask or a cloth mask. Keep on watching your hands. We know that fomites do transmit COVID. We know that airborne is crazy high. It doesn't mean fomites don't transmit, it just means airborne is the highest risk, and avoid the crowded indoor spaces. And the reason for these primary prevention strategies is this next slide, just published about 2 weeks ago. And this is looking at long COVID among people infected after they were vaccinated. And what they found is that you had your 2 shots, and now they compare people who got COVID versus those who didn't. Sorry, can you see my slide? Because I just lost. There we go. So what they found is the people who were double vaccinated who caught COVID were still significantly more likely to die than the people who actually had not gotten COVID. And they're also significantly more likely to have long COVID. And it was still better than not being vaccinated in terms of your risk of death or long COVID, but it really was not very good. Enough so that the study authors were clear to say that vaccination before infection confers only partial protection. And so relying on it as a sole mitigation means is not a good way of going. And they emphasize the need for continued optimization of primary preventions of infection rather than relying on vaccines to get us through the next while. Oops, sorry here. My screen is having some challenges. Here we go. So how much exactly does vaccination reduce the risk of long COVID? So in the past, I was able to say, hey, 2 doses may buy you 50% protection from long COVID. We now know that's only about 15% based on new studies. And that goes along with at least 10% of people who had both their vaccines still getting long COVID anyway. We hope that 3 doses will be better, and I'll go through the data here. So what about the different subvariants and how does it work? So 2 doses of vaccines, we know that you had protection against long COVID, but it was better against Omicron compared to Delta. When you added the 3rd dose, your protection against Delta got significantly better, you can see. So the 3rd dose made a big difference for Delta. Didn't make as big a difference in reducing your risk of getting long COVID after Omicron BA1. Now we're in an area where we have BA1, BA2 coming on BA4, BA5, right? So what we see is that with BA2, which are the 2 bottom slides, long COVID is increasing again despite having 3 doses. So we're losing some of the protection against long COVID even more with the new variants. We don't have the data on BA4, BA5 yet. So what is an approach to care I can recommend? We know that you need to address the whole system. So not just the physical and mental health symptoms in isolation, we're working together, the meaning, the people describe the spirituality, the sources of support in family and community, because it connects together to help them do well. And the principal care defined by patient-generated quality group looked at access to services for everybody, reducing the burden of care for patients and making it easier for them to care for themselves, making sure we actually have continuity of care, that patient's medical home, because it's too many specialists, too long and too unpredictable otherwise, working together as a team of different disciplines, and try to make sure we're consistent. There's too much idiosyncratic, we'll try this, we'll try that, and patients can get hoodwinked by a lot of snake oil in that process. And making sure we include patients in research, and I'll give you resources for all of these in the presentation. So this is that whole process about how we recognize patients and families at the center of the team and the rest of us. And this is just some of the specialties that work together. We'll need to have a clear shared formulation. So planning together explicitly, not just hoping it'll happen, but really asking for the gaps to be filled by each other. This is a great resource to look at that lets you know what tests to order on a patient when you're first investigating the idea of long COVID, what is medical management, what is self-management you can support to. Looking to address the parts that you know you can have good evidence on. So diabetes, mental health, treatment, because you know how to do that. The other parts may be more difficult, and make sure you have other supports. There's a great article just published less than a month ago looking at top tips in managing how to assess physically in your office better in really easy ways as well. I also put in this quality standard. Now we're having guidance from World Physiotherapy about safe rehab. How before you start rehab, what should you assess for first? Because we know there's postural tachycardia and all these things. How does long COVID address with exercise? What are the standards for rehab and a safety first approach? And also guide in conserving your energy from the Royal College of Occupational Therapists. These are from the UK because they do a lot more work typically in getting ahead of long COVID than we are here. Occupational work's going to be an issue, and to support you there's actually a document from a global chartering service that certifies healthcare professionals that clarifies a recognition around the issues of long COVID and how to support people at work, which you can use in advocating for your patients when they're going back to work, and reference this document because they recognize that there's an absence of clear rehab pathways. They recognize there's less supports for patients now than pre-pandemic. And we also know there's a long wait time for diagnosis and treatment. So companies will have to adapt to these realities. And now, as I said, we have the case law to support to make sure they're not discriminating as well. Self-supportive patients is a big part of management. We're not going to have enough healthcare workers. It's going to be very much patient community driven. There's YouTube videos to help explain to family members and workers what COVID is like and long COVID is like. And having very practical goal setting and device supports, and there's actually strategies to support with that can help people begin to have structure and shape to a very uncertain future for themselves. Symptom tracking helps you, and these are both research and symptom tracking. So there's a great one from Yorkshire, which actually allows patients to enter their symptoms and track and share it, and it's meant to help in remote management of people with, or virtual management of people with long COVID, and it's designed by the NHS. So it has symptom severity scores multidimensionally looking and tracking easily over time, as well as functional assessment scores. There's a study from Saskatchewan and an app that looks at 3 groups: people with long COVID, those with COVID but no long COVID, and people never infected, and looking at how this is happening for them. I put in the link for the Zoe app, which is the one giving all the driving research in the UK, but we can't really use it from North America. But in case you know somebody from there, that's a link you can look at as well. There's 4 groups for long COVID Canada. TikTok has great narratives on supporting long COVID. There's a great group from the UK looking at long COVID kids, which has even rehab exercises and approaches and workbooks there. And the long COVID support program, which is really good for all of us, including health providers, in learning about what to do for support, but also what research can be involved in the next information. Guidance from the Ontario College, ministries saying they're going to be set up clinics on caring for long COVID across Ontario, but they're still getting going and their wait lists are already months long. The CAMH study I talked about, those of you living in Toronto can refer your patients there because they'll get enrolled in the study and get certain other treatments. And there's also the patient-led research collaborative. We know that healthcare workers are affected by long COVID as well, as was mentioned earlier. This is going to affect you. Make sure you get the support you need if you or a colleague is suffering with long COVID as well. And my screen has gone wonky again, my apologies.